Hi everyone. So in this webinar, I'm going to discuss medications for chronic pain. So pain medications can help, but they can also cause harm. Every person is different and reacts differently to medication, and only you can really decide if your medication is helping you or not. So what we're going to talk about today is discussing the different families of pain medication, understand how effective or ineffective they can be, highlight any significant side effects, and discuss how to reduce and stop medications if they're not working for you. So medications generally have quite a good effect in acute pain, so pain associated with tissue damage for injury or infection, because they actually work at blocking the pain receptors at the site of the injury. As we all know by now, in chronic pain, it's not the pain receptors at the site of the pain that is generally generating the pain. So therefore, they don't really have a huge effect because they're not working on that oversensitive area in your brain. They sometimes help a little bit due to something called the placebo effect. So you've taken something and your brain perceives that that should help the pain, and so that calms your brain down, that overactive pain centre, and that can help reduce the pain somewhat. So for that reason, medications are always only going to be one piece of the recovery puzzle in chronic pain. So we'll go through the different types of medications. There's paracetamol, a group of drugs we call non-steroidal anti-inflammatory drugs, such as ibuprofen, diclofenac, naproxen, aspirin. Opioids, codeine, cocodamol, dihydrocodone, tramadol, morphine, oxycodone, gabapentinoids, gabapentin, pregabalin, tricyclics, which are amitriptyline, and a type of antidepressant medication called duloxetine, which we sometimes use for chronic pain. So this is the World Health Organization pain ladder, and this was really came about for acute pain or pain for say cancer and palliative patients. It's really much less useful in chronic pain. So the general advice was we started with simple analgesics such as paracetamol, aspirin or non-steroidals, and then move up to the so-called weak opioids, which we'll discuss a bit in a bit more detail, such as tramadol, codeine and dihydrocodone. And then you could move up to strong opioids like morphine and oxycodone. So just to try and explain how we often talk about medication. So when we're trying to assess the effectiveness of a medication, we're looking at the benefit compared with placebo. Usually it's about 30%. We often talk about the numbers needed to treat. So that means the number of people who need to be treated for one person to have benefit. So ideally we'd like that number to be between 2 to 4 people, which would mean that you have to treat 2 to 4 patients for one person to have benefit. We also need to stress that the benefit does not mean that the pain disappears entirely, only that there's some improvement. Obviously, when we're looking at medication, we also need to look out for harmful side effects. So we also often look at something called numbers needed to harm. So this is the number of people who need to be treated to cause harm in one person. All of these things are rough averages. So ideally, you're looking for a low number needed to treat and a high number of patients needed to harm. A prescription for a medicine that doesn't work is a prescription for harm, and nobody wants that. So obviously we know if pain meds really worked for chronic pain, we wouldn't be doing these pain groups and the webinars. So starting with paracetamol, there is some evidence that it can be very slightly effective for chronic pain if due to osteoarthritis. There's no evidence that it benefits those with long-term low back pain. It's generally safe. It's not addictive. It doesn't require prescription. The number needed to treat is relatively low at 3 to 4, and the number needed to harm is 12. So moving on to the non-steroidal anti-inflammatory medications, you can either take them as tablets or we can give them to you in a topical form, which obviously reduces the risk of side effects. So for oral non-steroidals, there is some evidence of benefit in chronic low back pain, giving about a 10% reduction of pain. They're not addictive and some can be bought over the counter. Unfortunately, they have a lot of potential significant side effects. So they can damage the kidneys, irritate the stomach, causing stomach ulcers and potentially bleeding, raise blood pressure and increase the risk of cardiovascular disease and heart failure. Naproxen seems to be the safest. So as you can see, they've got a good number needed to treat at 2.5 and actually a reasonably high number needed to harm. And in fact, the number needed to harm for ibuprofen and naproxen is actually higher than that for paracetamol. But the issue really is that the potential side effects of the anti-inflammatories are much more significant and more serious as listed above. So topical anti-inflammatories, so topical is better than placebo in osteoarthritis, and the number needed to treat for OA is 11, giving a 50% reduction in the pain. So moving on to the opioids, codeine, dihydrocodeine, cocodamol, tramadol, morphine, oxycodone, fentanyl. So for chronic pain, the number needed to treat is about 4 to 5 for a 30% reduction in pain. Probably fewer than 1 in 10 patients prescribed opioids in real life will be helped much at all, with the benefit being modest at best. There are a few people who respond really well, and the general advice is if you've not achieved useful pain relief from the opioid prescription within 2 to 4 weeks, you're unlikely to gain any benefit in the long term. There are significant potential side effects with these drugs: drowsiness, addiction, sexual dysfunction, nausea, constipation, memory problems, and it actually can make pain worse. About 80% of people taking opioids will have 1 or more side effects, and up to 1 in 4 people will become addicted. So obviously that's not really great. So there is something called the opioid risk tool, which we did give out at the pain groups, but which you can access online, and you can complete that for yourself. And this is the scoring. So if the score is 3 or less, you're at low risk of addiction. 4 to 7 is moderate risk. And if you're scoring 8 or more, you're quite high risk of developing addiction to opiates and other medications such as the gabapentinoids. So gabapentinoids again has a different class of drug. So you have gabapentin and pregabalin. They have mild benefit in small numbers who have what we call neuropathic pain, which is pain caused by damage or irritation of a nerve, or in fibromyalgia. So the number needed to treat for neuropathic pain is 7.2 to 7.7 for gabapentin, but with quite a low number needed to harm there at 3.7. Pregabalin, the number needed to treat is 13 to 22 for fibromyalgia, and the number needed to harm is 3.7. There's no benefit demonstrated in those with non-neuropathic or non-fibromyalgia pain. They've got quite a lot of potential side effects and harm, such as they can cause weight gain, actually, particularly gabapentin, but often people just generally don't feel well on them, and it can affect your cause brain fog and things, and some people just feel really dizzy and quite unwell with them. And the other thing is that they can work with opiates and increase the risk of overdose if you're taking both an opiate and a gabapentinoid. So amitriptyline and nortriptyline are a class of antidepressant. They haven't been found, that we often use for chronic pain. They've not been found to be helpful for those with low back pain. They can have some small benefit in people with fibromyalgia. The number needed to treat is 3.6. Whereas the number needed to harm is 13.3. They do have significant side effects: drowsiness, dry mouth, dizziness, and they can actually increase your risk of falls and have been associated with impact on memory. These drugs belong to a group of drugs called anticholinergic, and we do have some information about the risks of anticholinergic medicine on our website under that Am I Taking Too Many Medications tab. So duloxetine is a type of antidepressant that we sometimes use for chronic pain. Again, it can be helpful in neuropathic pain or fibromyalgia, with a number needed to treat of 6.4 to get about a 50% benefit, and the number needed to harm is 11. So just to stress again, medication can help, but they can also cause harm. For the medication to have been effective, we generally, if you take your pain on a scale of 1 to 10, we would only class the medication as being effective if you're getting at least a 2-point reduction. So let's say your pain score was 8 and you take the medication and your pain score comes down to 6 or less, then we would take that as the medication is helping. So I think, the big thing is to ask yourself 2 questions. Does the medication help relieve your pain on a scale of 0 to 10? And can you do more things after taking the medication? Because that's obviously one of the things we're really hoping to do, is to enable you to be more active, which can then in turn actually help your pain more, which we'll discuss more in next week's webinar. So if the answer for your medication is a strong yes, then it is definitely worth continuing. If you're not sure or it's firm no, then it isn't worth taking them. And be honest with yourself. Don't risk long-term harm if they're not helping. So we wouldn't suggest anybody comes off their pain medication really quickly. It all depends on what dose you're on and how long you've been on medication. And it is very much a case of slow and steady wins the race. We know that often people will have withdrawal effects when they're trying to reduce their pain. And because that makes you feel unwell, it often makes your brain feel less safe. And so it can feel like your pain's actually exacerbating, as well as you feeling not great generally. So the best way to do is to just reduce really gradually. And be confident you can do it. Your pain will not get worse, and you might even find it gets better, particularly if you've been on opiates. And it's always worth listening to stories of other people who've successfully come off medications and changed their lives. So just to summarise, pain medications can be helpful, but unfortunately for most people with chronic pain, they don't help much. There is a stat that says that they help 30% of patients to reduce their pain by 30% of the time, which obviously isn't really a great return for all these potential side effects. But even if they help a bit, they're only ever going to be part of this solution. Assess your own response to your medications. You'll be different to others. Do not take medications if they're not helping. If they're not helping, the only thing they're doing is potentially causing you harm. Please do not stop any medication suddenly without discussing it with us, and don't confuse any potential withdrawal as evidence that they were helping. Thank you.